Webinars and Clinics Committee. Today's topic is Approach to a Child with Trisomy 21, which is one of the commonest chromosomal abnormalities seen in children, involving birth defects, developmental and intellectual delays. It's my honor to introduce today's speaker, who is my colleague, an astute clinician, as well as a dear friend of mine, Dr. Sujin Mariam Thomas. Dr. Sujin has completed her MBBS from Government Medical College, Tanjavur, MD Pediatrics from Pondicherry Institute of Medical Sciences, and has worked for brief periods in several institutions like JIPMER and Lifeline before joining our hospital in November 2019. Presently, she is working as Assistant Professor in the Department of Pediatrics. Without further ado, let's begin our session. Over to you, Dr. Sujin.
Thank you, Deepa, for that kind words. Good evening, everyone. Today we're going to see how to approach a child with trisomy 21. So this is the most common genetic disorder in a child, and so they have many rights and privileges of their own. So it's a word by a famous actor, Sarah Gordy. I have Down syndrome, but that is not all I am. So let's see what are they. So Down syndrome. So every year we celebrate Down syndrome day on 21st March. So Down syndrome is characterized by a variety of dysmorphic features, congenital malformation, and other health problems and medical condition. So more than a normal child, they need special care, special monitoring, and evaluation, but they can do a lot. So Down syndrome is the most common chromosomal anomaly, as we already discussed. The impact of Down syndrome in each individual is different. That is, it's different from person to person. So some are being profoundly affected, while others are able to live independently as an adult. So what are the clinical features? It affects a wide variety of systems, cardiovascular system, GIT, endocrinology, hematology, growth, musculoskeletal system, and CNS, skin, eyes, and respiratory system. So let's see each individually. So what are the key facial features of Down syndrome? They have a flattened nasal bridge, and then the eyes, they have brush-wheel spot, epicanthic fold, folded or dysplastic ears, low-set small ears, brachycephaly, brush-wheel spot, open mouth, protruding tongue, furrowed tongue, short neck, excessive skin at the nape of the neck, narrow palate, abnormal teeth. So these are some of the salient features of clinical facial features of a Down syndrome child. So why it is important? So most of the cases by prenatal screening and genetic chromosome analysis, we might have diagnosed Down syndrome. But suppose if we didn't, then we have to identify all these facial features to look for the Down syndrome child and keep them in close follow-up for comorbidities to address. So how are the extremities and skin? They have short, broad hands, incurred fifth finger with hypoplastic middle phalanx. They have a transverse palmar crease. The space between the first and single toes, there is a wide space that is called sandal gap, and they have hyperflexibility of the joints. So in the skin, they have palmoplantar hyperkeratosis, and in 41% of Down syndrome, they have this feature. Seborrheic dermatitis, fissured tongue, cutis marmorata, geographic tongue, cirrhosis, alopecia areata. So these are some of the skin conditions they have. So it's a picture depicting the sandal gap and the palmar crease, the single palmar crease in these children. So coming to the joint and arthropathy, they have an atlandio-axial instability. So excessive mobility of the articulation of the atlas and the axis. 13% of the Down syndrome children have this deformity. So it can lead to spinal cord compression, and it affects 2% of the cases. So in symptomatic cases, they have neck pain, torticollis, gait abnormality, loss of bowel or bladder control, and sometimes signs of quadriparesis or quadriplegia. And Down syndrome arthropathy is 6 times more common than the general population. And mostly it is a polyarticular disease, sometimes oligoarticular disease. So coming to the gut, pulmonary, and endocrine system, the pulmonary atresia or stenosis is very common compared to the general population. They have sometimes there can be an annular pancreas in 2.5% of the cases. Imperforate anus, esophageal atresia with tracheoesophageal fistula, Hirschsprung's disease, celiac disease. So these are some of the GIT problems. So we'll see how to monitor for this in detail. And some of the pulmonary problems are the obstructive sleep apnea, asthma, and disorders of pulmonary vasculature, parenchymal lung disease, chronic aspiration syndrome. And coming to the endocrine, they have thyroid disorder, type 1 diabetes, that there are 3 times more risk than the normal children. Hematologic and immune disorders. Right from the birth, they have many hematologic problems. So starting in the neonatal period, they have this neonatal polycythemia, and that means that hematocrit is very high. So they have macrocytosis, that large cell volume and size. And they have this very grave condition called transient myeloproliferative disorder, that it exclusively affects the newborn with Down syndrome. So sometimes it can lead to fetal systemic disorders like pulmonary disorders, CCF, renal failure, like that. Sometimes it goes off benignly, only during examination we'll find that. So we should keep in mind while addressing a newborn with Down syndrome, so that we can do a complete CBC, peripheral smear, and evaluate for this transient myeloproliferative disorder and keep them in close follow-up. They have more they have a tendency for acute megakaryoplastic leukemia and acute lymphoblastic leukemia. So these conditions are more common in Down syndrome children than the other population. And immune disorders, they have this chemotactic defects, decreased IgG4 levels, and they have quantitative and qualitative abnormalities of the B cell and T cell. So they have inherently low immunity compared to the normal children, compared to the general population. So coming to the Down syndrome heart, they have wide variety of congenital cardiac condition. Most common is the complete atrioventricular septal defect. It is 37% of them have. And ventricular septal defect, atrial septal defect, partial atrioventricular septal defect, tetralogy of Fallot, PDA, and other miscellaneous condition. This is a logo of Down syndrome heart condition. This ribbon with a heart. So vision and hearing. The refractive errors are more common in Down syndrome. They have a high tendency for myopia, hyperopia, astigmatism, and they have strabismus and nystagmus also. So hearing disorder, 38 to 78% of children with Down syndrome have a hearing disorder. Most common is otitis media, and sometimes they have this congenital hearing loss in 15% of the newborn. Intellectual disability. So almost all individuals with Down syndrome have cognitive impairment, although the range is very wide. Most are mildly, that is 50 to 70 is the IQ. Sometimes they are moderately intellectually disabled, 35 to 50, or sometimes severely impaired with the IQ of 20 to 35. Autism is also a common comorbidity in Down syndrome. And in the adult life, they have more prone for early dementia and Alzheimer's. So speaking of that, these are the famous people with Down syndrome. So one is first picture is of Pablo Pineda. He's a university graduate and he's working as a lecturer. And next picture is of Chris Booth. He's a famous British actor. And another one is of Tommy Jessop. He's also a famous actor. So these are the famous people with Down syndrome, and they are doing great in their life. So coming to the diagnosis, so how will we identify a Down syndrome child? So we have lots of prenatal screening programs before birth itself, that the risk assessment, then the confirmation test with the coronary killer sample karyotyping. And after birth, based on the clinical features, if we suspect, then we'll go for karyotyping, chromosomal analysis with a confirmatory genetic test. Sometimes, so Down syndrome, if it is due to a chromosomal anomaly or a translocation, or it's due to mosaicism, right now, with our current diagnostic condition, any this thing we can identify with a detailed genetic evaluation. So it is prudent to identify these children early and get a confirmation test and keep them in follow-up. So what are the prenatal screening available? So some coming to the combined test, that is the maternal serum beta HCG and the maternal papa, it's a glycoprotein, and the UST measurement of the nuchal translucency. This is a combined test. So this markers, it's present from the 13th week of gestation onwards. but it can do up to 18 plus 6 weeks of the gestation. The full integrated test is the NT measured at the 11 weeks gestation, and the PPA measured at the 10 weeks gestation, and this measurement of the four quadruple markers combined with this integrated test. Based on the risk stratification, they will assess the risk, and if the risk is very high, they will the dentist can advise a complete gene analysis using a chorionic villus sampling, amniocentesis, or a fetal karyotype. These are the definitive tests. So quadruple markers composed of the AFP, unconjugated estrium, total or intact human chorionic gonadotropin, and inhibin A. So these are the maternal serum markers. So these are the prenatal screening available. And once you diagnose, how will you manage this child? How are you going to follow up this child? So at birth, you can do a thorough physical examination. And when you have the clinical features, then you go for a chromosome analysis. And once you confirm the diagnosis, at birth itself, you should do an echocardiogram and radiographic swallowing assessment, because they have lots of, as we already discussed, they have lots of GA problem, and the GERD, gastroesophageal reflux disease is common in them. So you do a radiographic swallowing assessment and assess the risk for aspiration and GERD. Then you can keep them on drugs or follow. And next is the eye exam. In the newborn time at birth itself, you do a thorough eye examination, hearing assessment, hearing screening at birth, then clinical assessment of neodental atresia, and also you should do a complete CBC with peripheral smear. And other problems like apnea, bradycardia, and desaturation are also common. So evaluate for all these things at birth itself, and then research. First year, they are more prone for constipation because of thyroid disorder or Hirschsprung's disease. So evaluate for constipation. If they found to have any of these problems, then advise and give treatment accordingly. Then every year you should do a hemoglobin and thyroid screening at first month, then at sixth month, then annually. And they are also prone for recurrent respiratory infection. So sometimes if it is very severe, you have to keep on antibiotic prophylaxis. Other remedial measures like thickening of feet and propped up position thing you can advise. Then cervical spine positioning. If they are going for any procedure, anesthesia, then you can advise of cervical spine positioning. You can do an X-ray and assess the risk for atlantoaxial instability. And if it is present, you can advise accordingly. And audiology evaluation at 6 months again. After at birth, we did a screening test, then evaluation at 6 months again. And after that, you can do a confirmatory test with the BERA at 1 to 5 years. So when they start preschool or when they start schooling, you can advise them for an occupational therapy as well. So sometimes children with abnormal hearing, you have to provide them with the hearing aids. And if the hearing is after that also poor, then you have to go for special education for these children and assist the children for obstructive sleep apnea symptoms. If it is present, you advise them or you give them home remedy. And ophthalmologic assessment also you should do annually. And if they have any symptoms of celiac disease, you evaluate them, and if found to have celiac disease, you keep them on diet and other supplements. And physical and occupational therapy and speech therapy should also go side by side. And once they are, you should approach them individually, and every child should have a individualized education plan. Then vaccination. So we already discussed that they have a very low immunity. If the immunity that you found that immunity is low, or otherwise also you can advise them 23-valent PPSV. And if they have any cardiac problem or respiratory disease, then compulsorily they should go for all the conjugate vaccines. And also after 2 years, this polysaccharide vaccine also along with your conjugate vaccine. So these are so this is the growth chart. So coming to the monitoring, their growth, their height and weight will be little different from that of the general population. They are more prone for short stature and obesity. So when you plot their growth in a growth chart, you have to plot them in a Down syndrome growth chart. So this is an example of a Down syndrome growth chart available. You have to download it and plot it in the Down syndrome growth chart, not in the regular growth chart. So coming to the other follow-up issues, they are more prone for all the dental problems. So the periodontal disease and teeth malalignment, I think, is also common in Down syndrome children. So annual health checkup, also a dental checkup is advisable for them. And also they are more prone for this hypotonia and associated motor problems. So a physiotherapy consultation and regular physiotherapy at home or at center is advisable. So every aspect they need extra care for them. And if we regularly monitor them, they can grow to their full potential. And also every year checkup, you should include and you should screen them for any malignancy with a peripheral smear. Peripheral smear. So if you found any suspicious blast cells, then you can go for a bone marrow to look for any malignancies. Once it's identified, in early treatment can prevent most of them. Otherwise, other respiratory problems and cardiac problems, once you do an echo, and you should screen them annually. And these are the monitoring of the Down syndrome children. So coming to that, we are coming to the end of the presentation. So at the end, I would like to share a video on Down syndrome children. It's made on it's an animated movie based on a Down syndrome child.
Hold your eyes, keep my heart on the table. Sometimes what's in my mind doesn't show on my face, though. I wanna fortify without fossilizing, redefine all the people I've been. Breathe inside each moment I'm in, then walk into a new horizon. I'm trying to find my freedom. Trying to find my freedom, freedom. I wish that I could feel the sun without casting a shadow. Just sleeping in a soft bed, damping my halo. Yeah, I made plans, takes time to change though. Or is that just worse to say? Don't heroes stand outside the fables? I'm trying to find my freedom, freedom. I'm trying to find my freedom, freedom. Oh, oh, nah, nah. Trying to find my freedom, freedom. Oh, oh, nah, nah. Oh, nah. I'm trying to find my freedom, freedom. Oh, oh, nah, nah. Oh, nah. I just wanna stay in the now, now, now. In the now, now, now. I never wanna stray from the now, now, now. From the now, now, now. I just wanna stay in the now, now, now. Never wanna stray from the now, now, now. Scream to a page in the now, now, now. I lost my way from the now, now, now. I saw your face in the now, now, now. I know you've got away with the now, now, now. So take my hand and take me to the now, now, now. Oh,
Thank you. Thank you for the patient listening.
Thank you, Dr. Sujan, for that wonderful, informative, and systemic approach to a child with trisomy 21. Indeed, an extra chromosome just makes them extra special. If anyone has any queries or questions, we would be happy to answer them now. Okay, considering there's no questions, before we wind up our session, I request Dr. Arun Maman, President of IAP Pathanamthitta, to add a few words.
Thank you for the invitation. The talk was good. I congratulate Dr. Sujan for the excellent talk, and I congratulate the new Church Medical College for the initiative taken and for sensitizing the practitioners regarding the diagnosis of trisomy 21. And on behalf of IAP Pathanamthitta, I once again wish you all the best, and let us conduct such sessions more in the future. Thank you.
Thank you, Dr. Arun. So we come to an end of today's webinar. I wish you all the best and have a great day.